Alright, so this chapter will cover bowel elimination. Where does digestion begin? Digestion begins in the mouth and ends in the small intestine. The stomach is an area where we can store swallowed food, mixing food and digestive juices, and the stomach is also a place where contents are emptied from the stomach into the small intestine. Now, what does the stomach produce and secrete? Pepsin, hydrochloric acid, mucus, and the intrinsic factor. Pepsin and hydrochloric acid help with the digestion of protein. Mucus helps to protect the stomach. Now, the intrinsic factor helps with the absorption of vitamin B12. In the small intestine, chyme, C-H-Y-M-E, mixes with digestive juices like bile. Now, there are three parts to the small intestine. The duodenum, where chyme is continuously processed. The jejunum, where carbs and proteins are absorbed. And the ileum, where water, fats, vitamins, iron, and bile salts are absorbed. The duodenum and the jejunum absorb most of the nutrients. The large intestine is divided into the cecum, colon, and rectum. The colon is divided into the ascending colon, which is that right portion of your abdomen, the transverse colon, which is that upper part of your abdomen, descending colon, which is the left side of your abdomen, and then we have the sigmoid colon. Chyme enters the large intestine and proceeds to the colon. The colon absorbs water, sodium, and chloride. If the peristaltic contractions in the colon are fast, diarrhea occurs. If the peristaltic contractions in the colon are slow, constipation occurs. The rectum is where bacteria convert stool to its final form. When stool reaches the rectum, the distension causes relaxation of the internal sphincter and an awareness of the need to defecate. At the time that you are using the bathroom, the external sphincter relaxes and abdominal muscles contract, forcing out the stool. Sometimes when people strain, they may elicit the Valsalva maneuver and they can pass out. Now, for pediatrics, the sense of the need to defecate usually doesn't happen until about 2 to 3 years of age. This is the same for urination. Now, would someone with a colostomy have self-concept issues? Yes, their clothes might cover it, but the individual knows that the colostomy is there. They may be worried of smells or leakage, or maybe giving someone a hug. They may be scared that their stomachs would touch and that they could hear the bag, or they might press on a stool. Now, whenever your patient recognizes that you are a nurse, that you are an RN, they may state that. They may state that they notice, well, I've got an RN to help me to the bathroom, and that can make you feel better. So we have to keep that in mind when we are having these patients come in and they're having a risk for self-concept issues, okay? We need to make them feel good, feel better, okay? Now, on page 1106 for the 8th edition, there's table 46-5, and that provides examples of laxatives and cathartics. I do want you to be familiar with these, get to know some terms there, okay? I also would like you to review the boxes and the tables on page 1098 1100, and 1101. All right. So the most common types of enemas are soap suds enemas, and that is where Castile soap, most of the kits, they'll have the Castile soap, and you just have to add warm tap water. Okay. There's also Fleet's enema. That's a common type of enema, and that is a lubricant laxative. Okay. Now, when we're talking about bowel, the NG tube or the nasogastric tube comes into play. Now, you won't learn this in your skills course for this term, but you will in the next term. You'll learn more about NG insertion and maintenance, things like that. Now, an NG tube is a tube that is inserted through the nose to the abdomen. Now, pages 1108 and 1109 do discuss these briefly. I do not want you to go into detail. You just need to have a general basis of the purpose of a nasogastric tube, okay? Now for colostomies and ileostomies, the pouches can come in one and they can come in two pieces. Same for urostomies. There are different skin barriers that are applied around the stoma to help the pouch stay and to protect the skin. Now, we call these barriers wafers. These wafers, they adhere to the skin around the stoma. We don't want them too tight around the stoma because that can cut off circulation. We don't want them too tight too loose over the stoma, because then we can have those gastric contents and stool leak onto the healthy tissue. Now, I do want you to keep in mind that you should inspect the stoma daily. It can be cleaned with soap and water. Now, most of the times you're going to have patients that will change these yourself, or the colostomies themselves, if they've had it for a while, if they're able to do so. Now, typically, they change the pouch every 2 to 3 days, okay? When we talk about peristomal skin is the skin around the stoma. What color should the stoma be? It should be pink or red, moist, and shiny, okay? The peristomal skin can sometimes have a redness to it, but it should not differ so much from the normal color of the abdomen, of the skin on the abdomen, okay? Now remember that overuse of laxatives and enemas can delay normal defecation reflexes. I do want you to read over diet on page 1089 of your 8th edition fundamentals book. Now typically surgery has an effect on the bowels. Anesthesia can slow the system down. Direct manipulation of the bowels, so surgery, colon resections, direct manipulation of the bowels can temporarily stop peristalsis, okay? Now, would these patients be able to eat after surgery? No, they need to remain NPO until bowel sounds are present. And even then, they will advance very slowly. Some doctors might say sips of clears, then to clear liquid, then to full liquid, and then to regular. Some might go ahead and start off on clear liquid diets. But just know that patients that have direct manipulation of the bowels will not be able to take anything by mouth after surgery, okay? Now, everyone knows what diarrhea is, but what can occur with diarrhea? Dehydration and electrolyte imbalances. Now, when we're talking about C. diff or C. difficile, there is an alteration in the normal flora in the GI tract when antibiotics are given. When this alteration occurs, this can put the patient at risk for developing C. diff. Does alcohol kill C. diff? No, alcohol does not kill C. diff. You must wash your hands, okay? When we're talking about constipation can occur due to an improper diet, a reduced fluid intake, lack of exercise, and even certain medications. Fecal impaction is unrelieved constipation. Fecal impaction is unrelieved constipation, okay? Now, when we have bowel diversions, when we talk about bowel diversions, we have surgical openings that can be created from the ileum, which is an ileostomy, or from the colon, which would be a colostomy. Depending on where the ostomy is, the stool will differ as far as its characteristics, thin or thick, more liquid-like. Now, an ileostomy is created with the ileum. The ileum is part of the small intestine. Now, for the ileum, the stool would be liquid and more frequent for an ileostomy. A colostomy of the ascending colon would be of the same nature. Ascending colon is on that right side of the abdomen. Now, if we're talking about a transverse colostomy or a descending colostomy, the stool would be more solid because at that point, water is drawn from the stool and it starts to form. Correct? Okay. Now, with a sigmoid colostomy, this releases near normal stool. Okay, it's lower in our digestion process in our GI tract. Okay. Now there are 3 types of colostomy construction. We have loop, end, and double barrel. But I do not want you all to get caught up in that. I just want you to know that there are different techniques for different types of patients. Loop colostomy construction is typically performed in emergent settings, and it can be reversed. So therefore, it would be a temporary or a reversible colostomy. Okay? Whenever we talk about colostomies or urostomies, ileostomies, I want you to make sure that you know what you're looking for as far as the stoma, the skin around the stoma, for colostomies and ileostomies, how the stool would be for that particular type of bowel diversion. Okay. This is the end of the bowel elimination chapter. Please remember you are responsible for reviewing your self-concept chapter, your urinary elimination chapter, and your bowel elimination chapter. Good luck on your test I guess by now, if you're listening to this, you've already taken your test. I hope you all did good. I will see you Thursday. Thank you. Bye-bye.